Good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System, broadcasting live with you from the Dole Simons Family Studio, and delighted to be back with you on this gorgeous Wednesday morning when the temperature is supposed to get to 65 degrees. Spring training fever is in the air. You can feel it, and you can feel the sun rising. But don't take off your masks yet. It's not time to do that, despite what the state of Texas just did. We'll probably talk about a little bit about that this morning. Hey, we are welcoming into our studio today Dr. Ryan Taylor. He is a transplant hepatologist, and Dr. Tim Schmidt, who is a liver transplant surgeon. He is the director of transplant here at KU. We're going to talk to this morning about a small study with some disturbing data around the impact of COVID-19 on liver transplant. The doctors are going to break it all down for us here in just a moment. We're going to have a great conversation about the whole safety questions around COVID-19 and transplant. I look forward to this conversation all morning long because, first of all, these are great guys. You'll have a good time visiting with them. I love to give them both a really hard time, so that's going to be fun this morning. And I think we're probably going to learn along the way. But first, Hawk Guy, how are we doing?
Yeah, we're still doing pretty good. I think in the Kansas City region, we're doing really good. Our cases continue to decrease.
Do you see that 3-day rolling average? I think yesterday was it like under 100 in Kansas? It's crazy how much better the numbers were.
Good, like we were in June almost. So, but you know, we have people continuing to do the right things. Again, it's warm. People want to get out, and the tournament's coming up, so people are going to want to get together. But if
you
we
mean
can
March Madness? I'm thinking.
Yeah. You know, if we can continue to be vigilant, we can continue to have decreasing cases. But so far, we're doing good at the hospital here. 15 active infections with 5 in the ICU and only 1 on the ventilator, and still 31 in that recovery period. Hayes is doing well also with 12 total infections, 7 acute, and 5 in that recovery period.
1 on the ventilator in the acute. That's just crazy good, right?
That's really good.
I mean, when these will get back down to 0, which would be a hoot. Don't take off your mask, people. Otherwise, you don't want to see what's going on down in Brazil right now, right? Let that be a warning to you. The variants are out there. Things started to relax a little bit. They didn't have that many people immunized, and all of a sudden, they have a really high peak again. Another surge can come if we relax. And we know that infection control is doing the work because what did you say about that influenza map today when you were driving in? Who said that?
It was all green.
It is
almost 0 cases of the flu nationwide.
And why is that? There's only one good reason, man. Masks work. Vaccination work. Do not throw away your shot once that comes. So first of all, before we jump into our discussion with our 2 guests, let's see if there are any reporter questions out there.
Hey, it's Cody at Channel 9.
Hi, Cody.
Good morning. You know I'm going to ask about Texas. I know you talked about it, but
Cody, you cut out, but here I'm going to respond to the question. I do, and I was texting with a good friend of mine last night she is the chief quality officer down at UT Southwestern, and I was giving her a hard time. I just said, uh-oh, and I sent the letter, and she wrote back, and she said, yeah, Texas it's not a good thing, but the local authorities, especially in major urban areas, are not relaxing their masking mandates. They had those mandates in place before, and the hope that they were going to be able to get before the state did, and thought they would continue. She was afraid a little too much politics going on. And I think there's probably some truth to all of that when you stand back and look at what some of the states are doing and you say, guys, this is a really populous state. You got Dallas, San Antonio, you have Houston. I mean, gosh, this is Austin. You got really big cities and big areas. Don't relax yet. Masking works. And again, you just have to look at influenza. You have to look at the rise in the variant. Don't go and stress stuff. Now, that doesn't mean you can't have people going back to bars and restaurants properly seated apart, properly distanced. But community transmission of COVID is still there, and it's been minimized because of the work you've done. As soon as you stop doing that work, the community transmission hasn't stopped, right? Say that again. The community transmission has not stopped. It's just been brought down because of the good work we've done. Once you take away that work and you liberalize stuff, the community transmission is going to accelerate until you have enough people vaccinated that you can prevent it from doing that and prevent it from getting another foothold. And we just don't have that yet. You know, we're looking at evidence now that says there will be enough shots to vaccinate every American by the end of June. That's impressive. So we've been at this for almost a year, in some parts of the United States more than a year if you look at Seattle, Washington. Think about what that means. You're into March, you got March, April, May. then you start thinking, I can really back off. So you've been at it for 12 months. Don't fumble the ball at the 10-yard line, because we're really close here, people. Don't fumble the ball at the 10-yard line. Okay, I'm
Yeah,
done.
you know, I would agree. I think we have, in the Kansas City area here, we've been extremely fortunate. We haven't been like New York, Louisiana, Detroit, Chicago, California, Houston, because I think a lot of our citizens and our legislatures have made right decisions to help reduce the amount of spread. And if we can continue to do those things right now, because it does even look better with the new rollout of the vaccines and the anticipation of the new rollouts, especially, you know, by the end of the month, by the middle of spring, all that is going to help. So.
It's going to make all the difference. But look, if you let the virus take hold, and if you let the variants take hold, things get a lot harder.
Mm-hmm.
And I think if we can just keep our masks on and keep things safe, keep each other safe, we'll do a lot better job. But that doesn't mean you can't have businesses open. You can have businesses open. You can have restaurants and bars open, appropriately distanced. Keep your mask on. The time when we can take our masks off is coming. Don't fumble the ball this late in the game. Cody, did that answer your question?
It did, and I'm back now.
Awesome.
I have a quick question about vaccine access, and I know many people are now, all of a sudden, everybody's an internet expert trying to go on different websites, different county health departments, trying to find. I have a couple of friends who are saying, I'm going to other rural counties to try to see if there are any spots open. What say you about that? Should people be trying this hard? I mean, in an ideal world, they wouldn't be. They would be getting it. But just curious your thoughts on people really trying to go around to other places to get vaccine.
Yeah. You know, Cody, I love your question, except I think everybody's been an internet expert now for a while. My patients come in with these brilliant ideas about what they're going to be treated with. Like, no, wait a minute. No, you know, that is a great question. And Missouri and Kansas are very different in this regard. We heard Secretary Norman talk a little bit about this yesterday. And in counties where, you know, maybe there's not as much uptake of the vaccine, and yet you're getting your vaccine based upon your county population. What's happening is some of those counties are saying, gosh, I don't want to waste the vaccine. And I think that's right. If you've de-thawed the vaccine, it's been sitting on the shelf or in the refrigerator, you've only got a limited amount of time you can give it, then don't waste the vaccine. That's like the worst possible thing. On the other hand, I think what you also heard Lee Norman say is we're going to start pulling back and redistributing some of the vaccine to the counties that are behind, either because they've had more uptake or there's been some population change or something like that, or you need doses because patients are leaving and going into nursing homes and they haven't been vaccinated yet, and things like that. So I think I think Kansas has got a good strategy for that. Hopefully that will continue to take effect. We'll see it go forward. I think Missouri's a little different. Missouri's challenge is that they have the mass vaccination centers. And the way that people know how to go to do that is really through internet access and things like that. And so as a result, without working through health departments as much, I think the people who have the best internet access are getting on and getting into those mass vaccine sites. And so I saw the article in the Star yesterday about, you know, Quentin Lucas is going to appeal to Washington, D.C. about the problems in the Missouri things and distribution, and that the 10 zip codes in the Kansas City metropolitan area are all predominantly white, and that there's been it's not been equitably distributed. I don't know all the data around that. I don't know as much about Missouri as I do about Kansas, but clearly it looks like that you need a partnership. I think what's happened in Wyandotte County is a good example. You know, Wyandotte County's really worked hard at finding everybody to come up and get a vaccine, and I think that they've, you know, used that approach to their mass vaccination clinics, and I think that's been a success. I think Johnson County has said, look, we're going to let the health systems help us, and we're going to let and the county's going to do some as well. And I think so it's kind of a team approach. I think the more you look at this as we have to get everybody vaccinated, and that means we have to form a team approach and work through every modality to get there, the better off you are and the better equality you'll have around distribution. I think if you just look to a hospital and say, give us your patient list, which is what KU would do, and you don't have a health department or an FQHC or someone else to partner to get the people who may not have as easy access, then I think you run the risk of having a certain population getting vaccinated and other people not getting vaccinated. So to me, if you really want to be fair, you try and have to go through all the modalities you can, whether it's through pharmacies, health departments, health system, or state-run mass vaccination clinics. And I think what we're going to see is as vaccination floods the market over the next several months, as we get a lot more vaccines, then I think we're going to have to see those partnerships really thrive in order to get everybody vaccinated. Hawk?
No, I agree. I mean, I think it's, once we can have the supply and those other places can get distributions of the supply, it's going to be a lot better.
Yeah. Other questions? All right. Well, let me first turn to Ryan and to Dr. Schmidt and Dr. Taylor here. Let me welcome you guys. The data around alcohol-induced liver transplants coming out of transplant centers across the nation, including ours, is going up. Increased alcohol consumption leading to hospital admissions for alcoholic-related liver disease is up nationally in some hospitals by 40 and 50%, and a serious consequence of liver disease is cirrhosis and transplant. Here at the health system, alcoholic cirrhosis resulted in transplant in 2019 of 38.5%. It's up higher than that during the pandemic. So talk to us a little bit about the impact of alcohol, the pandemic, what are you seeing in the transplant population? And then we're going to start talking about how your transplant patients are doing.
Yeah, I think alcohol certainly is the #1 indication for transplant right now. And you've seen the studies out there that the increased use of alcohol as a coping mechanism for the pandemic, the stress, the isolation, has really skyrocketed. I've said this before, that alcoholism and cirrhosis I thought used to be a transplantable disease at age 50. 50-year-old men got transplants for alcohol cirrhosis, but now we're seeing it in 40-year-olds, 30-year-olds, and I think we are about ready to list a 20-year-old patient who has alcohol cirrhosis.
Ouch, that's like really young.
Yeah, and I worry about my kids because they're 20s, and I was like, how do people get alcohol cirrhosis by their 20s? And I think the pandemic has really caused uptick in drinking and the amount of drinking. And I know you've probably seen this in the inpatient service, Ryan. The acute alcoholic hepatitis is really on the rise.
Absolutely. You know, people can get into trouble in a hurry with alcohol, and they sometimes just don't appreciate what damage is being done. And so it's critical that people are aware of that, be conscious of that. Alcohol doesn't work well with other liver diseases. So if people have fatty liver, hepatitis C, or other health problems of their liver, alcohol just adds to the trouble there. So it is a problem, and we need to get awareness to make sure people are being safe.
So just as a broad question, how are patients, before we talk more about some of these specific diseases, I want to get the heart of this issue, and should have said, we want to get the liver of this issue. So talk to me a little bit, how are transplant patients doing around this time of COVID, and have you transplanted someone who ended up having COVID?
Yeah, we've had a patient who actually came in for a liver transplant who tested positive after we already had the organ in. That person did well, and we've had some patients in the post-operative period. We follow upwards of 1,000 patients, and we've had quite a few patients had COVID. I don't know if you know the exact death rate for and incidence for our COVID patients, Ryan, but I know for the kidney patients, we follow about 1,600 patients. We've documented 152 patients with COVID, and 15 of those have died, so it's almost a 10% death rate for our kidney transplant patients.
So if they get it, they have a high death
Yeah.
rate. And so you don't want them to get it, obviously.
No, and it's, you know, they're sick, they have diabetes, hypertension, heart disease, on immunosuppression. Obviously, they're sicker than the general population, and that's why they have a higher rate of death. But the liver patients, do you have the exact numbers, or do you know the numbers on those patients, Ryan?
I'm aware of one liver transplant patient that has died with COVID, but most of ours have recovered. So actually, some of the liver transplant data suggests that patients with liver transplant and get COVID do actually as well as people without a transplant. And so this is really very fascinating because we're all worried about the immunosuppression, but in some of the data is starting to show that the immunosuppression itself may be somewhat protective because it's that overreaction response that patients have with COVID that get them into trouble. And so with the immunosuppressions, that might be blunting it somewhat and preventing some of these really severe reactions that we've seen.
And Dr. Schmidt, do you think it's because I think you mentioned this, that the kidney transplant patients just have more generalized other diseases like hypertension and coronary disease, et cetera, than the liver transplant patients have, and they tend to be a little older, I think.
Yeah, I think kidney patients are generally sicker. They're, I think, end-stage renal disease is usually a harbinger of heart disease or diabetes or long-standing other medical comorbidities. And in the transplant event, we always worry that the kidney operation itself is smaller, but the patients are quite a bit sicker. Liver patients tend to be otherwise healthy. All they usually have is liver disease, but I think that explains why kidney patients have a higher mortality after getting COVID than liver patients.
So let's kind of head back to alcohol for just a minute. Not that I'm trying to go to the bar or anything, but how much do you have to drink to get liver disease, guys? I mean, Ryan, talk to us a little bit about this relationship between alcohol and liver disease, and then let's bring that into fatty liver as well.
Absolutely. Well, the joke is you always should drink less than your hepatologist. So that's, but we won't go there today. But, it's controversial and everyone has different views on it. But, alcohol's been through society for a very long time. So it's something that's been there and will continue to be there. But we have guidance from the CDC that if an adult male has more than 14 drinks a week or more than 2 drinks a day, they're at risk of chronic health problems from alcohol. And for women, it's 7 drinks a day or more than 2 in a day. 7 drinks a week or 2 drinks in a day that they're at risk of chronic health problems. So obviously it's something that we can use safely, but can certainly lead to other issues and complications.
Well, so, for some people, that's not a very big threshold. So how do you know if you're getting into trouble?
It can be really tough, and that's why we've seen so many younger patients come in. They just think it's just impossible that a 25-year-old who goes to the bar every night could show up jaundiced and need a liver transplant. But you can get into trouble in a hurry. A lot of it has to do with how your body metabolizes alcohol, how your size and, smaller petite people may have higher blood alcohol levels quicker than larger people. There can be other genetic differences that play a role in that. But many times you don't know until you start turning yellow. And if you're turning yellow, it's too late. So blood tests that your doctors can do can check it, but I can tell you I see people drink, a lot every day and they have normal blood tests. So I want to disconnect that the blood tests tell the whole story for our patients.
So that's an interesting thought. And as you get older, does your liver have a harder time handling the same amount of alcohol as when you were young?
Not necessarily. I mean, we certainly know we have the lifers who drink hard their whole life. I see patients who say they've had a case of beer every day since they're 15 years old, and
oh my God.
You look at their labs and they're
okay. I just gotta say, how do you ever get out of the bathroom like that? Because I would be in the bathroom the entire time.
It surprises me sometimes at the amount of liquid intake that people have and are able to do this. I mean, astounding numbers of cans of beer that people have. But the reality is there's some people have been drinking their whole life and, they just seem to tolerate it better. If we could figure that out, I think it would be wonderful and helpful for our patients. But we just don't always know what a safe amount of alcohol is. And patients always want to hear from me in our group, how much can they have? Because they want to know that. And it's really, I believe, an individualized decision. You have to look at their other health problems. Are they using this responsibly? Are they drinking, in a responsible manner? They're not binge drinking or overdoing it, which can also lead to problems as well. So I think you have to talk to your patient. You have to get a sense of where they are with their health and give them appropriate guidance.
So given that it's hard to know how much alcohol you can have before you have liver disease, tell us again the general guidance numbers that you put out there for men and women.
Yeah, so for men, if you have more than 14 drinks in a week, the NIAAA, which is the government entity that researches alcohol, says that you're at risk of chronic health conditions or more than 2 drinks in a day for men. And then for women, it's more than 7 drinks in a week or 1 drink per day for women. So women have a much lower threshold. And we are seeing rises in women that are coming in with liver disease, especially at younger ages.
So Hawkeye's signaling me. Now, I don't think you drink that much, right?
I don't. I really want to try to get in my 1 glass of wine a night for cardiovascular health. But just asking a question, you've given those daily drinks and weekly drinks, the cumulative. What about the people that go out and binge drink, say, on a Friday and Saturday night to the bars, and they're saying, well, I can get in my 14 drinks here on these days. Does that have any difference?
It does. So certainly they're showing increased risk of health concerns if for men having more than 5 drinks a day and 5 drinks in a setting, and then for women 4 drinks. And part of the problem with the binge drinking is not only the health effects, but then you're getting high blood alcohol content. Obviously, you're then at risk of getting into alcohol-related trouble if you're driving or having other instances. So it's not only the effect on your liver that those high numbers of drinking, but all the other negative effects that can happen in the psychosocial environment.
It's also, I think, important to understand that the CDC, 1 drink is 1.5 ounces of alcohol or hard liquor, 4 ounces of wine, I think, or 8 ounces of beer. So a drink at a bar, mixed drink,
much,
is
right?
is a 2.5 drink. So you don't have to drink that much in order to get your daily quotient of
Yeah.
what's safe. It's really and impressive to see. And I think, I don't know if it's your experience too, but when we talk to these patients who come and see us, a lot of the older alcoholics were, weekend drinkers or heavy drinkers with just beer. Now it's daily drinking of spirits,
Yeah.
vodka, hard alcohol, whiskey.
Wait,
It's
wait,
daily
wait. Are you
use.
saying that whiskey counts as alcohol?
It does.
That's unfortunate then,
I know.
isn't it? Okay.
Good old Jack Dan. But I think
Yep.
there's also high calorie and sugar content in a lot of those.
Well,
drinks,
yeah, I
too,
think you
so.
see in fatty liver disease, diabetes, unhealthy diets, not a lot of activity in combination with alcohol increases our risk now for liver disease because the lifestyle of the regular United States citizen is not active. And if you add alcohol onto obesity or diabetes, it compounds the issue.
Okay, so Ryan, another question, which is this relationship between liver disease and or alcohol and fatty liver disease. Talk to us about that.
So the real epidemic in hepatology right now is fatty liver disease. And so there's some estimates that up to a third of Americans may have some degree of fatty liver. And that has to do with all the reasons Tim just mentioned with our diet, lack of activity, obviously some genetics thrown in there. And the pandemic has been really hard on fatty liver because we're all in front of screens. We're not getting out. We're not traveling. And so we've disrupted our normal activities. And then, of course, the fridge is only a few steps away for most people, or the snacks and everything. And all the kids are home for school. Everyone's diets, I think, have declined substantially because of this. So it's really been a perfect storm of our lifestyle really catching up with us, and then we're stressed and worried. We drink more. And so these things actually become multiplicative in damage, not additive, meaning 1 + 1 = 3. If you have fatty liver plus alcohol, you're going to be more likely to have liver problems down the road and faster damage.
Yeah, these are pretty big deals altogether, and it feels like the pandemic has really affected all of that. And talk to us a little bit about the change in liver allocation, because I know that's changed right around the time of the pandemic, and we don't get numbers like we used to get. So talk to us a little bit about that, Tim.
Yeah, the United Network of Organ Sharing is the government contracted agency that controls how the organs are allocated. And this year in February, it went from in February of 2020, it went from most of the organs coming from a local source, meaning our Kansas and Missouri area, to now the organs are distributed at a 500 nautical mile from the donor hospital, which is about, I think, almost 600 ground miles. So now we are getting organs from Kentucky, Wisconsin, Texas, and whereas we used to get 90% of organs from the local area, and now we get about 50% of our organs from a national area.
You mentioned a story was it yesterday or very recently about going to get an organ in Kentucky?
Yeah. Yeah, we were going to get an organ in Kentucky, and they were transplanting in that same hospital with an organ from Chicago. So organs were flying across the state, and people were getting transplanted for similar disease in the same places, and it's a lot of logistical nightmares what organ allocation has become. And our heart transplant, 95% of our organs come from outside of our area. So they fly all over the place just to get organs. When our OPO does 50 to 60 heart transplants procured in our area, we do about 50 transplants, but none of our hearts come from our area.
Yeah, it does seem crazy to me that when they changed this legislation, we were all involved in trying to work on this a lot, and we didn't get to the heart of there I go again, the main point here being that the performance of organ procurement organizations is so different from one area to the others. And if you didn't have a very good one, you wanted to get organs nationally. And if you have a really good one, you didn't want to give them all up. And we're blessed by the Midwest Transplant Network, who does an amazing job at organ procurement.
Yeah, the Midwest Transplant Network is probably number 1 or number 2 in all metrics in the nation. I mean, they're a fantastic organization, whereas some OPOs across the country have a lot of opportunity for improvement. And that kind of baseline function of the OPOs was overlooked when they came to allocation. And now, there has been some movements last year to try to regulate OPOs more to improve their ability to procure organs. That probably won't have an effect for the next 5 years to actually get everybody up to a level that's equal to where we are now in our area.
Yeah, that's a problem.
Yeah, I
That's
mean,
a real problem.
if there were more organs, more people get transplanted. If we change allocation, you just change where people get transplanted. You don't actually do more
Yeah,
transplants.
I think they're really missing the boat here. I think the
Yeah.
real issue has been, if you have an underperforming OPO, let's address that before you try and bring organs in from other areas, because that just doesn't seem right or seem fair. And they just totally miss it. They spend all this time on trying to redistribute for millions and millions of dollars to fly these organs around the country, when what they really need to focus on was, why is your OPO underperforming?
Yeah, I mean, why, you fix the foundation first, and all the other stuff would have gotten
Fixed.
improved.
Yeah.
The OPOs, there are some great ones in the country, and there are some that can do a lot better. And if they all did better, way more people get transplanted, because one more donor can be two kidneys, 2 lungs, a heart, a liver,
Yeah.
7 transplants. Whereas if you just fly different organs around,
You won.
the cost of this, we spend a lot of money on transportation nationwide. All programs are now spending more money on transportation, and it's just putting people at risk. There's always a story of a procurement team not making it back because they had a flight crash.
Yeah, that is no good. All right, Cliff, you're substituting the day for Bob, who's substituting for Jess, who's substituting for Jill. Not
to
that
the
you
bullpen.
feel like you're coming off the taxi squad or anything like that. No, Cliff does a great job, so we're going to welcome him in this morning. Let's hit the questions.
All right, we have several along the transplant line. The first one is there any data out there on the efficacy of the vaccines for organ transplant recipients on anti-rejection medications?
Ryan, what do you think? Any early news here? And we'll turn to Hawk after that.
Yeah, absolutely. So the CDC says that if you're on immunosuppression and you've received a transplant, you can receive the vaccine. Unfortunately, in the Pfizer, Moderna trials, they didn't have these patients, so we'll have to get this data as we move forward. But we are vaccinating all of our transplant patients just like any other patients with chronic health conditions.
And are you seeing any difference after that vaccine? Is it too early to tell, or?
I think it's too early to tell, honestly. I've not had any patients that have had any trouble with it. What I can say is the transplant patients are extremely eager to get the vaccine because obviously they know what the stakes are. So, but so far, so good.
I don't know if you know any data out there, but I know that one of our nephrologists has tested some patients for antibodies after the vaccine and seems to be not as responsive as the general population. I don't know if there's any data
Yeah.
out there.
I don't know. So we do know, especially what Dr. Taylor said, is you can get it. And we know that a lot of transplant places have protocols for getting people vaccinated with pneumonia vaccine, influenza vaccine after transplant. And I think if you continue with those protocols, you're going to be okay. But, Dr. Taylor, Dr. Schmidt would be the experts on the most up-to-date data for that population. And I think it depends on how much and what immunosuppression you're on. Can you mount an immune response? But again, a lot of these patients after transplant are going to be getting vaccines normally at some point after transplant, whether that's 3 months or 6 months. I would just caution if you are testing for antibodies after, again, it's not recommended. I think if you're doing it in a trial setting, you should do that, because we know here at the health system, if you test for antibodies here, you're probably going to be negative if you got the vaccine and are just testing for that, because our antibody tests test only for antibodies against the protein found on the virus itself, not the spike protein. So that's the other thing to be concerned with.
All right, our next question from our viewer is, my husband is a post-6-month transplant patient and has not received a vaccine. Any idea when he might be eligible?
That's a great question. Hawkeye, what do you think? This is really a class question, or a phase question, not class phase.
Yeah, I think it is kind of, unfortunately right now, it is kind of the phase issue. We do know, especially in the hematologic malignancy, basically the blood cancer group, that you have that immunosuppression there, so you are at greater risk of adverse outcomes after. There is a push to get certain conditions moved up in the phases to get the vaccine, but right now there is not that.
Yeah, and some states are approaching this a little differently. In some places you're more eligible than in others, but Kansas has been, we're going to go through the phases outlined by the CDC, and we're going to be moving from phase 2 to phase 3 once we complete the 65 and above, and then I think transplants are in phase 3. Thoughts about that, guys?
Yeah, I mean, we certainly would like to get all of our patients vaccinated, but I think with the supply-demand issue, it's probably unrealistic to try to make it a special group, unfortunately.
What do you think, Ryan?
Yeah, for Kansas, solid organ transplant recipients are in phase 3. And if you have chronic liver disease and not a transplant patient, you're considered phase 4 in the state of Kansas.
And I'm sorry, I would like to piggyback onto what Dr. Taylor says. You know, seeing those candidates for liver transplant in my clinic before they come in to make sure everything's okay, we give them 3 and 4 vaccines at one time. And I would like for that to be able to happen, for somebody to get a vaccine prior to transplant. And I think we will get there. Just as you said, there's going to be a lot of supply, and we're going to be able to do it. Just right now, today, we can't do that.
If you remember what it was like back at the beginning of this pandemic, and we were talking about masks and how to make your own home mask, because we couldn't get enough masks out there, and so people were wearing all sorts of kind of things out there, and you know, and it was pretty cool, man. We had people come in tying knots and stuff and showing us how to put them on and all that, and that was a problem of supply.
Yeah.
Now we're talking about how we can't get people vaccinated, and it's because we have a problem of supply. The supply problem, however, is a short-term problem. Now, it feels long-term because we've been in this pandemic for so long, and we all wanted the hope. And I remember when the Pfizer data came out, and we were sitting at this table and we were talking about it, and we said, look, folks, we have been on the defensive for the last entire pandemic. Now, for the first time, we are going to go on offense, game on, and those vaccines are like Patrick Mahomes at quarterback. They are so effective. And now everybody wants them. And now we all want Mahomes right now. And I think what's going to happen, what we'll see is over the next 6 weeks, we're going to watch a marked increase in supply.
Oh, yeah.
So I'm talking to Lee Norman this week, and if you see the discussions going around and the Biden administration saying yesterday and Fauci saying, we will have enough vaccine for Americans by the end of June. Now, remember, initially we were talking about next fall.
Yep.
Now we're talking about June. We have just moved up the timeline. I think you're going to see this. Here's my prediction. Take it for the crystal ball that it represents, which means it's incredibly foggy and probably wrong. We're going to get through phase 3, or phase 2, I think, is sometime here in March and early April. And then I think we're going to have a very short phase 2, I'm sorry, in March and maybe the beginning of April as vaccines really hit the area. Sometime around middle of April, I suspect, we're going to be going into phase 3. I think phase 3 is going to last a few weeks, and then we're going to hit phase 4. Partly because phase 3 is not as big as phase 4 and phase 2, and partly because I think we're just going to go open season after that.
Yeah.
I'm going to predict that by May sometime, that we will have enough vaccine in our market that we're just going to be telling you, bring your arms. So let me answer the question. The question is, when will a transplant recipient be logically thought to be offered the vaccine? It depends a little bit about where you live. You know, again, talking to some folks, my friends in Texas and other states, they're already doing it. But I think in Kansas and probably in Missouri, you're looking at April and May, hopefully in April. And I'll tell you, I think everybody's going to get this offer in the very near future. And what you have to do is be ready to put your arm out, because we need your arm. We can't help you without your arm.
Ashley asks, could you explain what OPOs are?
There you go.
The OPO stands for Organ Procurement Organization. They are the private contractors with the government who go and do all the legwork at the hospitals to try to get the patients to become donors. So
And to say that some OPOs are much better because they've done so much work with people long before they ever make it to the hospital. They're in the schools, they're in the churches, they're in different, trying to get people to understand the importance of organ donation. You know, I've got it on my license, my driver's license card, but that doesn't really do anything until I put it in my living will or something like that. I mean, it's in my living will where it says, man, if I'm sick and impaired and dying and I want to give all my organs away, please take them. Now, nobody may want them. I'm getting too old anymore. But I think that our OPO has done a magnificent job at reaching into the community and getting people to think about that.
yeah, they reach out to the community, the hospitals, the government agencies. I mean, they do a tremendous amount of work. And no matter what time of the day, what holiday, weekend, they're always there face-to-face with that donor family to try to procure an organ. There was one study out of New York that the neighboring OPO, Pennsylvania, which has a great OPO similar to ours, if the New York OPO would perform as good as the Pennsylvania OPO on a metrics performance, they would have had 200 more donors in the year 2019 And 200 more donors equals
That's like
1,000
thousands
organs.
of organs. Yeah, that's a big deal. So just to say, for anybody out there, if you ever know anybody, or hope if somebody from the Midwest Transplant Network is listening,
Say thank you.
thank you. We so appreciate you.
And I think this goes along the line of the second question I asked. But Freddie and Lisa ask, how soon can a critical worker with a liver transplant get vaccinated? They're 3 years out from transplant.
I would think any time after transplant would be a safe time, maybe not within the first few weeks after the immunosuppression is really intensive, but any time after transplant would be a safe time for the vaccine.
What do you think, Hawk?
For having the vaccine?
Yeah.
Yeah, I mean, I would agree. I think we want to make sure that you have the least amount of immunosuppression on board as you can, and that's, again, so that you can mount that immune response. I don't think it's any safety issue at all. It's just we really want you to be able to mount an immune response, an adaptive immune response with B cells and T cells. So the lower the amount of immunosuppression, the higher chance you will have to mount that protection.
And Hawkeye, do you think that means they should get one vaccine over another? And we've said the vaccine
No.
you want is the one that's going to get to your arm, but do you think it makes any difference if you get a booster shot from Moderna or Pfizer versus just one shot?
No, not right now. So one shot versus the Johnson & Johnson versus
Yeah.
Moderna? No, again, I think what we have seen from the data between these three vaccines is that the very important points to remember is they significantly reduce your risk of hospitalization and they significantly reduce your risk of death. Both of those, the mRNA vaccines and also the non-replicating adenovirus vector vaccine from Johnson & Johnson do that. So I think those are the important things to remember. If you have a chance to get one, get it.
Ryan, what are you saying to your patients, both before and after transplant? As you're the medical director, what are you saying about the importance of vaccination?
I bring it up at every visit. I ask my patients if they've received it, if they've gotten on a list, are they planning to receive it, try to make sure to dispel any myths or misunderstandings they have about it. You know, our visits are critical to help, provide the medical knowledge and scientific basis of why we should get vaccines. So I take that actually as a sacred part of my job to make sure that we're talking about vaccination with every patient.
And COVID as well as influenza vaccine and the MMR
Yes,
and tetanus and everything, yeah?
But I do that
Absolutely.
with my HIV patients too, and some of them have hesitancy and reluctance, but, it's still, I definitely recommend that they get it. And
Yeah,
it's
I think-
safe for them, and it's going to be protective for them.
In the near future, I think it'll just be an addition to the vaccines you guys
Yeah.
advised right before transplant,
Yeah.
so they're
Absolutely.
they're ready for it before their transplant.
Mary asked, is there a non-medical means of reducing the damage of fatty liver, such as diet, exercise, and et cetera?
What do you
Ryan?
think, Ryan?
This is the easy answer. So the only thing right now that's shown consistent, proven to work against fatty liver disease is actually diet and exercise. So we don't have an FDA-approved treatment for fatty liver. So it is diet and exercise is the way to approach it. So we all should be doing that, but it's absolutely critical in this disease process.
So Ryan, let's talk a little bit about that because fatty liver is such an epidemic in the United States. Do you have to be fat to get fatty liver?
Absolutely not. And what's kind of scary is the leaner you are, the thinner you are in fatty liver, the worse your outcome. And so they've done some studies showing that the patients who are thinner who get fatty liver actually have more trouble. That's probably because there's more genetic factor rather than environmental factor in those patients. But no, it can, I've seen patients who are 400, 500 pounds and have not a spot of fat in their liver. And I've seen patients who are 130 pounds and have severe fatty liver. So I'd like people to understand fatty liver is not just a weight issue. It's a metabolism issue. So if you're doing the right things to have a healthy metabolism, then you're going to be helping your fatty liver. So that means
Okay, so I was going to say, does that mean lots of whiskey and beer, or what does that mean to have a healthy, what's your healthy diet here?
So a healthy metabolism is, I like to think of people need to understand fatty liver is a disease of overnutrition. So we have to look at what calories we're putting in our body. What are the components of that? Are we eating, junk food and getting our calories? Are we having proteins and vegetables and things like that? Then you want to look at how much you're taking in. So, are you eating too many calories, having excess energy? And then like any system, you have to burn that energy off. So are you doing something on the back end to reduce your energy storage by continuing to have activity and burn energy?
So does this mean that the Cherry Republic cherry gumdrops that I love, those are not good for fatty liver? Is that what you're saying to me?
I think the gumdrops you'll be fine with, but if you're doing it every 5 minutes, we'll have trouble.
Okay, I'll reduce my frequency a little bit.
And along that line, Debbie has a question. Is there a way for a person who doesn't seem to be having any symptoms be able to tell if they have a fatty liver?
All right, what are the symptoms like, Ryan? What do you do?
So the scary thing about fatty liver is patients usually have no symptoms. And so only until a doctor does a blood test or they go to a screening fair or a checkup for their work insurance, something like that, that they get blood tests back, and then that's how they find their way to our office. So the starting point for this would be to get a physical with your physician, get basic blood tests done. That can many times show liver tests that are elevated, which are a sign of fatty liver. And then we can also do an ultrasound if someone has high liver tests to look for fatty liver there. And then there's other technologies and things we can do beyond that to make the diagnosis.
And Ryan, so what it says if we don't really know what the warning signs are, and you have to get a blood test to do it, where can people go learn more about this fatty liver thing? If we don't, if, you know, after a day and they still have questions, where would they go to find out more?
You know, you always have to be a little cautious with Dr. Google, but there's a lot of good resources out there for fatty liver. You know, the American Liver Foundation has a nice website with information. The American Association for the Study of Liver Diseases, which is the main society I work with, also has a lot of good resources for patients. But there's a lot of information on basic fatty liver out there. You know, it's really just common sense, you know, good sense living. You want to be cautious and knowledgeable about what you're taking in, making sure you're staying active, all those things that any general practitioner is going to talk to you about during your physical.
All right, so moderation makes all the difference, right? Of everything
Absolutely.
we do. Yeah,
Absolutely.
except for exercise, and then just go do a bunch.
Dr. Hawkinson, this is probably aimed towards you. You mentioned a daily glass of wine as a cardiac benefit. Can you expand on that?
I knew they were going to be watching. You said that, Hawkeye. Well, look at it. Well,
You know, I think there is, I don't think there's conflict between our hepatologists and our cardiovascular physicians. But, you know, moderation of alcohol has shown to be somewhat cardiac protective, especially in terms of your lipids. And certainly, Dr. Taylor, you know, correct me if I'm wrong, but, you know, that we don't have really good drugs to raise your HDLs, your good lipids. Certainly we know that taking a small amount, again, in moderation, in the recommended doses of alcohol, particularly wine, and I don't think there's a difference between red wine and white wine, can have been shown to do that as well. So there is some cardiovascular protective effect of taking alcohol. But you really have to balance that, do it in moderation, do it in the recommended doses.
I keep hoping that red grape juice is going to help. But Ryan, talk to us a little bit about that from your standpoint of liver disease. Is it okay to have one drink a day? Is that recommended, not recommended? And what about grape juice?
You know, so bottom line is that you got to be cautious with this, and it all goes back to what Dr. Schmidt had said earlier on in this broadcast, is you have to look at the amount that you're taking. So for some of my patients, you know, a glass of wine might be the 64-ounce QT cup, you know, the big one. So I think you have to be a little bit cautious about how much you're having, but a little bit every night I think can certainly be okay for patients in that regard. And really it's the red wine that seems to have the most health benefits for patients there, and we just don't see that translate into the grape juice with the tannins and things.
Yeah, that's just unfortunate. It reminds me that we need to get Dr. Patrick Moriarty and one of our cardiology guys down here to talk a little bit more about this. I think it is a good topic, and we're going to talk about it soon.
I think we're going to see the effects of this pandemic on liver disease from both the fatty liver disease, from isolation, not exercising, you know, just being at home by yourself. Compound that with the stress and coping mechanisms with alcohol and other, even eating more and not doing things. I think we're going to see an increase in liver disease over the next, 5 years because of this.
And 10 years ago, what was the leading cause of the liver disease?
Hepatitis C was a leading cause up until 2017, I believe. Then we got a cure for hepatitis C.
Science.
Well,
see?
In science,
that's good.
You knew the infectious disease doctors got to bring up Hep C. It is a remarkable story, though, right?
Remarkable, absolutely remarkable.
You can testify to that, right? Because your clinics used to be full of hepatitis C, and it's just kind of like gone away.
We virtually don't
Absolutely.
see any hepatitis C anymore.
Just in a matter of a few years, it was the primary disease I saw. It was 70% of my practice, and now it's a rarity to really be focused on treating hepatitis C patients. So I had shared some of the data from our program that 5 years ago, we did a third of our transplants were for hepatitis C, and last year in 2020, it was only 2%. So really in a short period of time, it's disappeared. And this has been recognized. You may know the Nobel Prize for Science last year went to the scientists who helped make some of the discoveries that were critical for this. So it's really been one of those monumental scientific achievements, certainly the biggest in my career from a liver perspective.
You know, I do a lot of cystic fibrosis work, and talking about science with these amazing drugs in CF. Our inpatient census in CF used to run 10, 15, especially this time of the year, it might be 15 or 20. Last week, there were 0 CF patients in the hospital. Today, I think there's 2. I mean,
It's amazing.
it's just amazing. Science works. Yeah. Vaccines work too, people. Last question, Cliff.
All right, last question. Should people on immunosuppressive meds, not for organ transplant, hold their meds before or after getting the vaccine?
Yeah, that's a great question, Hawkeye. What do you think?
I would say talk with your provider that is prescribing those drugs. I think, again, it depends. What is the intensity? How much immunosuppressives are you on? I don't believe there's any formal recommendation, so that is a question that you and your provider need to specifically talk about. But from what I have seen from people that are on them for other reasons, not organ transplant, there really hasn't been a holding of those drugs. But again, talk with your provider.
And, you know, just to say, we think steroids, a higher dose steroids, especially 20 milligrams and above, may be the worst of all as far as trying to be too much of an immunosuppressant around that. So, Hey, tomorrow, Dr. Terry Rozelle is the director of the Ethics Consultation Service here and a professor in History and Philosophy of Medicine at KU, are going to join us with a discussion about ethical issues that have been a part of chronic disease and crucial conversations of the virus. He works closely with John Carney, the president and CEO of the Center for Practical Bioethics, who is also going to join. Hey, these two folks are great friends of Kansas City. This question about ethics and the interface of end-of-life care, what happens at the end of COVID-19, really important conversation. This will be I really hope that you all have a chance to tune in. We're going to also be talking about vaccine equity and the questions around having to carry a vaccination card. Again, Center for Practical Bioethics is going to weigh in on that. I think that's going to be a big conversation.
Yeah.
It is going to be interesting. Ryan Taylor, final thoughts for today.
I just want to thank you all for this opportunity. You know, liver disease is one of those things that isn't talked about all the time, and it's going to be a bigger and bigger problem moving forward for our society. So anytime we can have early conversations, an ounce of prevention is worth a pound of cure. So I think it's really important to have these conversations. Thank you.
All right. Thank you. Tim Schmidt.
Yeah, thanks for having us here. And I agree with Ryan. Liver disease is kind of the dark horse. People don't know about it until it's too late. So knowing about how to prevent it is important. And then if you have a chance, sign your donor card, talk to your family about donation. We need all the organ donors we can get.
Yeah, I'd just like to make a point of clarification from yesterday, and this kind of segues from that ethics. The U.S. Conference of Catholic Bishops, including our own Archbishop Naumann here locally, did put out a statement yesterday. And just to kind of paraphrase, so Moderna and Pfizer's vaccines were tested with aborted fetus cells, whereas Johnson & Johnson's vaccine production is with aborted fetal cells. So basically what they say is that when ethically irreproachable COVID-19 vaccines are not available, it is morally acceptable to receive COVID vaccines that have used cell lines from aborted fetuses. But they also do comment that the threat to humanity and the pandemic is so great that if you can choose between right now Moderna and Pfizer, certainly do that if it's available. If not, then get the Johnson & Johnson vaccine. You are not contributing to that moral, ethical dilemma, but we need to continue to talk with drug companies and vaccine companies to not use aborted fetal cells. So it is still okay to do that if there's no other vaccines available, and we know vaccines are in such short supply. But overall, getting the vaccination is an act of charity by you, the individual, to help protect your fellow citizens.
Yeah, perfect. That is so true. Hey, tomorrow, remember, we have the Center for Practical Bioethics and John Rozelle and team here. I think that's going to be a great conversation. Don't get cocky out there. Just because we're down to 15 patients and only one on the ventilator doesn't mean it's time to go out and party. You have to fight for your right to party. And you do that by following the rules of infection prevention and control every day. They are your best friend. And remember that your other best friend deserves the same amount of love as you want to show yourself. Take care of them. Wear your mask. Keep your distance. Be careful when you go outside. Wash your hands. Don't go out if you're sick. Cough into your elbow. Follow the rules. And then we're all going to be here tomorrow and the day after that and the day after that. because the vaccines are on their way. We're back with you tomorrow. Remember, until then, stay safe out there. There's still no place like home.